And next, we have Dr. Sumitha Agarkar. Ma'am will be speaking on optical interventions in myopia, myopia correcting spectacles, and contact lenses. When I discussed the talk with her, I said, see, everyone wants to listen to what is happening and with myopia correcting spectacles and it's everything about it. She said, yeah, this will be good. Thank you, ma'am. Dr. Sumitha Agarkar.
Good morning, everyone. Thank you to Dr. Srini and the organizing committee and AIOS members to allow me to speak in this symposium. I'll begin with a small tribute to Dr. Badrinath. And he did not teach me any pediatric ophthalmology, but he shaped my me as a clinician in more ways than one. So with that, we'll start with my talk on optical interventions. So myopia epidemic, as we all know, is increasing, and by 2050, we are expecting a huge increase in children who are going to be myopic. In our own study, Janani Shankar Netralaya, in schools, we have found that almost 25% of children are in private schools are myopic, which is a huge difference from what was reported earlier in 2003 and all, where it was just about 6%. So what are the strategies which we have? Basically in two large categories. One is optical and pharmacological, which is of course low dose atropine. So of all the optical intervention, these are the ones which are available in India and have been proven to be effective. Bifocal glasses, peripheral defocus glasses, multifocal contact lenses, dual defocus contact lenses, and orthokeratology. They have proven evidence-based effect on myopia control. So looking at bifocals and progressive addition glasses, so this is a possible mechanism that most of the myopes who, when they do near work, there is a higher lag of accommodation, or there is a high accommodative lag, which produces a hyperopic defocus, and this is a cue for axial elongation. And that's why the bifocal glasses were prescribed or thought. But it has not proved equally effective across the spectrum of children with myopia. At this point, probably role of bifocals is limited in children who have progressive myopia with high lag of accommodation. This is more than 0.75 diopter. And children who have esophoria for near, probably you can try bifocal add of plus 1.5 over their glasses. Multifocal glasses have not proven in COMET study any effective in controlling myopia. Now let's look at the multifocal or designs which have come, which produce a peripheral hyperopic defocus. So if you look at this diagram, you can see that if you give a single vision glass, rays of the light are perfectly focused on fovea in the center. But if you look at the periphery, because of the oblate shape of the eye, you can see that peripheral rays actually are focused behind, and this produces a hyperopic defocus, which is again a cue for axial elongation. So if you can produce a defocus zone in the periphery to make it artificially or by producing a myopic in the periphery, then this cue for axial elongation goes away. So new designs aim to create this peripheral myopic defocus by putting at different kinds of interventions to produce this myopic defocus in the periphery. So the first lens which was introduced in India was by Hoya, which is a MyoSmart lens. And again, it produced this defocus by multifocal segments, which produce a high myopic defocus of around 3.5 in the periphery. So it has a central 9 millimeter optical zone and a peripheral zone of 33 millimeter, which has lenslets of plus 3.5 diopters, as you can see in this design here, and they produce a myopic defocus in the periphery. So company and they have data. We have the longest data for this particular design. They have 3-year data as well as 6-year data, and myopic progression and shows 60% efficiency in efficacy in controlling the axial length, and compliance and adaptation was fairly good with children. And I have the longest experience with this particular design in our clinic, and we do find good control of myopia with the MyoSmart glasses. There is another, Essilor has also come up with this. They have, again, this is based on the same principle of producing a myopic defocus, but here the defocus has been produced. It has a by a concentric ring which is formed by aspheric lenslets. So optical element may be different to produce defocus, but principle remains same. Again, 60 to 70% efficacy in controlling myopia progression. HALT versus DIMS head to head. In only one study, HALT has proven a little bit better than Hoya's MyoSmart. And of course, there is another player in the field now, which is CARE technology, where defocus is produced by incorporation of cylindrical annular refractive elements, and that's why that acronym is CARE. They have two different options available at younger and older children, and central optical zone is surrounded by these alternating rings of correction. Again, adaptation is good. We have little less data about this particular brand, but they are just entered the market, and probably we should have more information on this lens. This is in future, that there are same defocus can be produced by translucent dots which are incorporated in glasses, and they reduce contrast at the retina and do not produce defocus actually. And it modulates the on-off pathways at retina. It has been proven effective in both younger and older children, and this is not yet launched in India, but we expect it within a year to get launched in India. Now coming to the soft contact lenses, the dual zone soft contact lenses, where again there is a central distance correction and peripheral addition by producing a myopic defocus in the periphery. This is the only lens which is so far approved by FDA for myopia control, unfortunately not yet available in India. Future, we are looking at an extended depth of focus contact lens designs. Again, initial trials are showing promising results. More trials are ongoing in this, and it's not yet launched per se. Coming to orthokeratology, they are based on reverse geometry, and lenses are worn overnight, which produce a temporary flattening, and it also increases the peripheral hyperopic defocus and provides clear vision as well as myopia control. So not only eliminates the need for daytime spectacles, but also slows down elongation. Reducing the back optic zone diameter in these lenses increases the efficacy of myopia control. However, they are more effective in younger children who show rapid progression and on high myopes, where we have nothing else except orthokeratology or drops. However, microbial keratitis remains a concern. So what are the risks of myopia control strategies with any optical devices? We have little information on rebound. Ortho-K lenses have known to accelerate progression on stopping the lens use and infiltrates, and they are of a primary concern in our country specifically where they're in. So where do we go from now? We know every diopter of control improves quality of life and reduces the risk later in age. So we should think about moving from prescribing single vision glasses, or at least offer the patients that. We have now increased options to choose from. It is a fast changing field, and I am hoping that with mass production, prices will come down. So to summarize, this is what it looks at this point in our country. Thank you.
Thank you, ma'am, for